Hi, everybody. My name is Stuart Schlosser, president and founder of MS Views and News. This is an MS Views and News educational program, and we are sponsored tonight by Sanofi. I would like everybody to please give a round of applause to Sanofi for sponsoring tonight's program. In addition to Sanofi, we had exhibitors. We had Biogen, Sanofi again, Bristol Myers Squibb, Genentech. We had Mindset, Novartis, and TG Therapeutics. So I want to thank them all for being there as well to give you the information that you need to receive. Dr. Greenberg is going to be presenting for approximately 35 minutes, and then we will do an open Q&A, okay, for 35 to 40 minutes if it should last that long. All right, thank you.
Great, thank you, Stuart. Can everybody hear me okay? I'm holding the microphone correctly. So I get to do my own introduction, which is spectacular. My name is Benjamin Greenberg. I'm a board-certified neurologist. I'm a professor of neurology at the University of Texas Southwestern. I'm a Gemini. I like long walks on beaches and gardening. Just got into gardening recently. And for some of you in the room who may have known me over the last almost 17 years here in Dallas, when I got here, this was all black. And thanks to 2 daughters and 2 stepsons, it is no longer all black. Both of my girls, I'll have some pictures in a bit, are now in college, which is hard to imagine. And as I think about how a lot has changed relative to my world and our world here in Dallas, much more has changed in the world of multiple sclerosis. And we're going to take a little journey this evening down history lane and then pan forward to where we're going. I'm supposed to remind you, I will not be taking questions during the talk, so hold any questions you have. If you have a pen, write them down, and at the end, we'll go through all the questions. So let's talk about how far we've come relative to multiple sclerosis. So if you look back in history and you ask the question, when was the first case of multiple sclerosis described? It goes back over 500 years. So there is a text that describes Ludwina of Scheiden, who was a teenage ice skater who had a fall on the ice and had a series of events. And when you read her medical history over about 10 years, it really sounds like multiple sclerosis. And it was recorded in very good detail. And so we have reason to believe that she was probably the first described case. So multiple sclerosis has been with humans for a long time. It wasn't until the 1860s when one of the absolute great-great-grandfathers of neurology, Jean-Martin Charcot, who ran a hospital in Paris, first did what was called the clinical pathologic correlation of multiple sclerosis. So he described individuals who had it, and when they passed away, he performed autopsies and correlated what he found in the brain with the symptoms they were having. And as you got to the 1860s, nobody knew what the cause of multiple sclerosis was. And in fact, if I were to poll you right now in terms of what is multiple sclerosis, I'd get a lot of different answers. But back then, the answers were much more varied. And in fact, our evolution of our understanding of MS is still going on today. And we're going to talk about that tonight. And then there was a milestone, both for the United States and the world, when Sylvia Lowry posted an ad in the New York Times in 1945, and it read, "Multiple sclerosis, period. Will anyone recovered from it please communicate with patient?" It was after her brother had been diagnosed. And back then in 1945, multiple sclerosis was a horrific diagnosis to receive because not only were you worried about disability, but there was actually a fatality rate with it, which we don't have anymore, thankfully. And this was the beginning of the National Multiple Sclerosis Society. And Sylvia Lowry went on to organize as people responded, and the National Multiple Sclerosis Society got started. Now, that's 1945. If you ask throughout the last 100 years, what was our conceptualization of the disease? Another way to say it is, what's going on in the body to cause the symptoms that individual has, you'd get very different answers. So if you came to my office in 1900, you wouldn't find me there because I wasn't alive. But if you came to an office in 1900 and you asked the physician what causes multiple sclerosis, they'd say, you're not sweating enough. Go to bed, get under the covers, get as hot as you can, and sweat as much as you can. Turns out, not accurate. If you get to the 19 teens, It was toxic exposures. You need to purge your system. Sound familiar to anybody? As you get to the 1940s, it was a blood flow problem. You have a problem with your arteries or veins. You need better circulation. Does that sound familiar to anybody? All these great theories come back over and over again. But it's in the 1950s and the 1960s that there's the first look into the immune system. So Paul Ehrlich, a German physician scientist in 1908, gets the Nobel Prize for his descriptions of the immune system. So throughout the late 1800s and the early 1900s, with microscopy, we first saw immune cells in blood and then started to study what they did. Now, Paul Ehrlich, who is brilliant and deserving of that Nobel Prize, stated definitively that the immune system was incapable of attacking the human body itself. And he called it horror autotoxicus. The horror of an autoimmune response could not exist. That if the immune system was attacking a human body, it was doing it to fight an infection, and it may play a role in cancer, but there was no such thing as an autoimmune condition. And that lasted for 60 years, 60 plus years. It wasn't until the end of the 1950s that Noel Rose, a physician who was in New York at the time, with his mentor, did work to identify the first evidence of autoimmunity, and it was in the setting of thyroid disease. And the publications come out overturning decades of dogma in science to show it's possible for a mammal to develop an autoimmune response to a protein within the mammal. They didn't believe it could happen. So that theory starts to enter the world of multiple sclerosis in the 1960s for the very first time. Up until then, even with Charcot, if you read Charcot's descriptions, 1860s, the microscope needed a candle to light the image. That's how far ago the technology was. His pathologic description of the brain is exquisite. It's just as good as anything I would get from a pathologist today. He saw immune cells in the brain. He saw a loss of myelin in the brain. He saw damage to neurons in the brain. He described it quite well, but connecting the dots was lacking. So it's not until the 1960s that this notion of the immune system pops in. And indeed, if you go to a neurologist, I'd say even today, and you say, what is causing multiple sclerosis? You will hear some version of this statement: an autoimmune response to the lining around neurons, the myelin sheath, leading to demyelination and various symptoms. And that's probably, that's what I was taught in medical school and in residency. And we're going to talk tonight as to whether or not that turns out to be completely true or not. Now, with the backdrop of this notion of an immune system attacking the brain or the spinal cord, we had phenotypes of multiple sclerosis. So you're not allowed to talk because it's going to mess with the audio, but by a show of hands, how many people have heard the terms relapsing, remitting, secondary progressive, primary progressive? Great. Just for those of you online, everybody raise their hand. And there are these bars that get taught to medical students and residents where every time that orange bar goes up, it's a symptom. So in relapsing remitting, everything's fine until a Thursday afternoon when your legs feel weird. And then by Friday, Saturday, it's worse and you have a relapse. There's an acute event and hopefully you get better from the event, hopefully back down to your baseline. But over time, this is untreated. Relapses can occur over and over again. And then for some individuals, the relapses stop, but every year is worse than the year before. And that's the secondary progressive phenotype of this disease. And then for some individuals, there is what's described primary progressive disease, where there isn't a relapse. It's just every year things are worsening, but based on testing, it looks like it's worsening due to multiple sclerosis. This phenotypic description of the disease has been drilled into the heads of every licensed physician and every unlicensed physician around the world for decades. And now we're realizing we are missing several pieces. So with this as a backdrop, science has spent the last 30 years trying to understand what is driving the orange bars. What is happening in a human on the Thursday at 3:30 to give the relapse? What's happening in the human who comes in and says, year over year, I'm a little worse? Why are things changing? And that work leads to a much more complicated set of bars. So you're going to look at this and say, I signed up for dinner. I didn't sign up for a science lesson, but unfortunately, you're my prisoner. So you're going to get a science lesson. So I want you to look at the green bars. Just look at the green for a moment. It should remind you of the relapsing remitting course and then going on to secondary progressive. That green bar represents symptoms. It might be loss of vision, it might be numbness, it might be weakness that comes and goes and comes and goes. And over time, the relapses stop and progression continues. Is everyone kind of comfortable with that? Head nodding, great. Now let's look at the orange bars below it. There are a lot more orange bars than green bars. The orange bars represent what's happening on an MRI. So it turns out that about 9 out of 10 MS attacks, if we define that based on an MRI point, have no symptoms. The immune system goes in and affects a part of the brain that you have so much reserve for, you don't even know it's happening. So the reason we keep ordering MRIs over and over again on people is because we know that you may be feeling great, but there's still activity going on the MRI. It's like a diabetic coming in and say, I feel wonderful, but we check their blood sugar and it's 300. And we say, well, we're glad you feel well, but you are not in control. The MRI can give us a sense that there's activity going on, but it's imperfect. Those orange bars are linked to those little blue dots on the left. And those dark blue dots around the red circle, those are immune cells in the brain. So as a certain set of immune cells leave your bloodstream and enter the brain, it causes the orange bar, which episodically gives you a symptom. Not all the time, but episodically. But if you look to that blue that's getting higher and higher in the bottom, those are not immune attacks by definition. That's loss of neurons over time. And what we have found is that even in the earliest stages of multiple sclerosis, there are neurons that are suffering and neurons that are being lost slowly. And then over time, that slow loss becomes more obvious to you and to your healthcare team. And that is what we think is driving progression. And indeed, if we look at tissue, what you're seeing in those green dots at the top, those are neurons that are swelling after damage. We can see that happening even without obvious inflammation. So there is a component to this condition that is either happening as a result of the inflammation or even on its own, separate from that inflammation. And we're trying to put the pieces together as to how they connect. But for years, because we could see the green bars and we could see the red bars. What I mean by that is you would tell your healthcare providers about the symptoms you were having. You would tell us about the relapse. And we would do an MRI and we would see the new scar. That's where the world focused. So for the last 40 years, we have been wholly focused on that part of the immune system and stopping those green bars. And we've done actually a really good job. So if you look at history, to the first effective drug proven in a placebo-controlled trial for multiple sclerosis, it was a drug called interferon beta. Anybody remember interferon beta? Yeah, okay. So what you're looking at here is the publication that came out in 1987. This is when it was first published, placebo-controlled. Half the people got interferon beta, half didn't. And you looked at the relapse rates, how many relapses were occurring over time, and interferon beta patients had less. Now I'm leaving off the title of the paper, which is my favorite part. The title of this paper was Intrathecally Administered Interferon Beta. The word intrathecal means directly into the spinal fluid. These patients came in for a spinal tap once a week, every week, to get interferon injected into the spinal fluid. Yeah, that's what I'm talking about. See me in back if you're interested. They got to the end of the trial, somebody pulled them aside and said, hey, you know you can inject it in the skin. And they were like, oh, damn it. All right. So interferon beta went from being administered into the spinal fluid into the skin, where it was very effective. And between the first FDA-approved drug, which was 1993, till today, we went from having a single drug to this. And this is an incomplete slide. We've got injections, we've got infusions, we've got pills, you want it, we got it. And the evolution of drugs has been nothing short of miraculous relative to relapses. Our ability to prevent relapses is outstandingly good. When I first moved to Dallas 17 years ago, the number one phone call I received on Friday at 4:30 in the afternoon was new symptoms concerning for a relapse and we need to sort it out. I have not been called for an acute relapse in one of my patients in years. I get other phone calls, but not relapses. And the drugs, as they've developed over time, have been exceptionally good. In fact, if you were developing one of these drugs and you were going to the FDA asking for permission, the way the drug would be judged as being successful or not was based on a statistic called the annualized relapse rate. So after interrupting your dinner with a science talk, I'm going to make it worse and give you a statistics talk. So this is the part where people get up and they go for the exits. But this is important to your daily decisions. So let's talk about how these drugs got approved. Some of you are taking medications that are FDA approved. What was the data that was used to decide if it worked? And it's very straightforward. You take a group of willing individuals who sign consent and they know what they're signing up for, and you enroll them in a trial. In the past, it was placebo-controlled. We don't do that anymore. And half the people get the drug and half the people get the placebo, and you follow them for 2 years and you count how many relapses happened. So if there were 10 patients followed for a year and they each had 1 relapse in the year, the annualized relapse rate would be 1. So 1 per patient, 10 total for the population, but an individual patient, 1 per patient. And you could compare the 2 arms. That really doesn't help you decide what drug you want to do. What you care about is these 2 groups. What you care about is if we look at the individuals who are getting placebo, some of them are having relapses. Some of them aren't. There were people in the placebo arm who didn't have a relapse. Not everybody has a relapse every year. In the treated arm, the box was smaller. When you're picking a drug, you really want to know, am I going to be in the red box or not in the red box? And we were never able to predict who was going to fail a drug and have a relapse or not. So we had to use this population statistic. And so we could count over time the annualized relapse rate. So the lower that number goes, the fewer the relapses the population is having. Everybody comfortable with that? Lower number, good. So if I pull back up the slide for the intrathecal interferon, the untreated patients had an annualized relapse rate close to 2. 2 relapses a year, if not being treated. By the time we got to the injectable therapies in the skin, the annualized relapse rate was lower. What you see here, and you don't have to read the small print, are drugs organized, these are all FDA-approved drugs, relative to their annualized relapse rate. And on the left, there's one that had an annualized relapse rate of 0.7, and on the right, that's 0.1. The latest drug is 0.08. What that means is a relapse every 15 to 20 years if you were to amortize it over a population. And so the drugs have gotten exceptionally good based on this at preventing relapses. And we've patted ourselves on the back for years that we're exceptionally good at preventing relapses, but there's something hidden in this data that becomes interesting about the disease. And that is, if you look at the placebo patients over time, they're not on any drug. Their annualized relapse rate's been going down. The annualized relapse rate back in the original interferon trials when we put in the spinal fluid was 2. By the time we put it in the skin, it was 1.3. As we get to the more recent trials, it's down to 0.3 to 0.5. Now, these are individuals on no drug. How did we do that? Was it mindset? Was it vitamin D? Was it stopping smoking? What's changed over time is our diagnostic criteria and how we're identifying patients. In 1985, when you entered the trial, there was no MRI. The only people being diagnosed with multiple sclerosis were ones with symptoms severe enough over time to get the attention of a healthcare provider to say this is multiple sclerosis. By the time we get to the 1990s and MRIs are being used a lot more in the 2000s, we're finding milder and milder patients over time. And as you have a milder disease, it's easier to put it into remission from a relapsing remitting point of view. So one of the ways to look at this is to take one drug that was used over and over again as a control and look at the annualized relapse rate. So this is a drug that's FDA approved, doesn't matter which one it is, but it was used over many years. And when it was first studied, the annualized relapse rate was 0.37. Outstanding. That's far better than a 1 or a 2. It got used as a comparator instead of placebo for trials recently, and it's down to 0.11. Are they manufacturing it better? Is it did the drug change? No, the drug didn't change at all. The population that we are enrolling in trials has changed, and our ability to suppress relapses has gotten exceptionally good. So a lot of us looked at this data and we said, now that we've done such a great job of suppressing relapses, what are we learning about this condition? And we realized that the relapses, which the majority of patients were suffering from, were distracting us from a lot of biology. And last year, a group of us published a paper using the term smoldering associated worsening. And embedded in this paper was the concept that there are biologies and pathologies happening in a human other than those immune cells going in and out of the brain that are leading to a slow worsening over time. And what's happened is we have gotten so good at suppressing relapses so that I no longer get a phone call at Friday at 4:30 with new symptoms. We finally had an opportunity to see what happens when you take those attacks out of the equation. And for some of our patients, nothing happens. They've had decades of stability and are doing great. But for another group of our patients, we've realized there's this slow worsening that's happening over time, and we need to both quantify it, understand it, and then intervene on it. And so the term that gets used a lot, you don't have to remember this, is something called PIRA, because we like acronyms. We can bill more for an acronym than if we spell it out. So progression independent of relapse activity. What that means is I'm worse today than I was last year, and it keeps happening, but I'm not having relapses. And it turns out if you follow cohorts over time from their very first event, if you follow a group for 20 years, 50% of patients at some point will experience progression without having relapses. This is a lot of our patients having this. And in fact, if you separate out patients who have progression independent of relapse activity early on in the course of their condition, they are the ones who are destined for having more disability from this condition. It is not just something to identify for academic purposes, but it is definitely something that is prognosticating an outcome. So we have started to focus on this with all of our resources on how do we intervene. And one of the challenges is how do we measure it? Because it turns out we all talk about our lives and our function in very different ways, and we all have different symptoms. And if I'm being totally blunt, some of us pay more attention than others. And if I'm being really honest, some of our families and significant others pay better attention than we do. And for any of you who are ever come to the UT Southwestern Neurology Clinic, you'll know the rooms are set up. I'm airing our dirty laundry right now in public. I shouldn't do it, but the rooms are set up that there's an exam chair where often the person who's the patient sits, and kind of behind them are chairs where family can sit. It's because while you're talking to us and saying, yeah, I'm doing well, your loved one is going like this. And I don't have to break eye contact with you. I can see them shaking their head and let them open the discussion of what's really happening. And so how do we measure progression over time if it's so important? And in the paper, what we talked about was moving from a world on the left, which was our goal for 20 years. What I stated the goal of therapy was to many of my patients was no evidence of disease activity. And what I meant by that was that inflammation. Get an MRI every year, check in every year, make sure you're not having relapses. We have now moved to the right side is of no evidence of smoldering disease activity. How do we find out if somebody is worsening over time? And this is really difficult to do and requires a partnership between us and you. And why is it so difficult? Well, it turns out our function can worsen for a lot of reasons. Some of them have to do with MS, some of them don't. So there's a whole host of biologies, things, the innate immune system, mitochondrial dysfunction, adaptive immune system, all these things that play a role in our functionally getting worse. Bottom left, aging can impact our function over time. So it happens to all of us. There are things you can do to intervene on the natural aging process and at least modify some of it. There are things you can do to make it much worse. So the reason we yell at people not to smoke is it accelerates that biology dramatically. And the physical activity that Travis was talking about is a great way to alter some of the natural aging that impacts your muscles and the way you move. And then the top left, lifestyle factors and comorbidities. It makes a difference in how we function. So we find that our multiple sclerosis patients who also have diabetes progress faster and further than those who don't. Our multiple sclerosis patients who smoke progress faster and further than those who don't. Our multiple sclerosis patients who have uncontrolled high blood pressure progress faster and further than those that don't. So just because somebody's worsening doesn't mean it's the MS biology. There are other things that are happening. So it challenges all of us to do two things. One is to track our progress. Are we stable or not? And then secondly, decide how are we going to intervene on it. So what I want to do with just the closing parts of my talk is focus on how do you track this? Because you are the most important tool there is for tracking progression over time. So what is our focus on tracking progression? Lots of different tools. Clinical monitoring, biomarkers, wearable-based data, and the top right, patient-reported outcomes. What fits into each of these categories? So clinical monitoring is checking in with your healthcare provider. It's the clinical MRIs that we do. The biomarkers, for some people in the room, you're hearing about blood tests you can now do to track activity, proteins called neurofilament light chain or GFAP. There are panels where we can look to see if proteins that are released from brain cells are going up over time. These are in the early stages of proving their value. I check them, I test them, I'm still sorting out how valuable they are. And so, but we're going to get to a world where just like a diabetic can check their blood sugar, an MS patient can check a blood test to determine are they in remission or not. We're going to get there. We're not fully there yet. Digital and wearable-based data. Turns out how much you move in a day is actually a pretty good marker for how we're functioning overall. It turns out if you have walking difficulties, you tend not to walk as much. If you have fatigue, you tend not to walk as much. If you're having any cognitive challenge, a lot of folks tend not to socialize as much. And so as you collect that data in the background, as all of our smart devices are spying on us all the time and listening to us all the time, and it's really creepy, you can use it for your good to track data and use this as a way to track. And then there are the patient-reported outcomes, the things you can do to quantify how your functioning is going and then share that with your healthcare provider. So how do we do this? I separate it into two lists. One is symptom tracking. We all tend to remember our best days and our worst days. As human beings, we stink at remembering average. It just doesn't get recorded. And so as you're thinking about your fatigue, you tend to think about the days where you were excessively fatigued, or I wasn't fatigued at all, and then you sit there trying to figure out what was it. I had a turkey sandwich at lunch. I'm only eating turkey sandwiches from now on, and it's not that simple. So tracking symptoms is important, but trying to figure out the patterns is tough. Cognition is tough as a symptom. So the most common cognitive complaint that we hear about in a multiple sclerosis clinic is word finding difficulties, knowing what you want to say and the word's not coming out or the wrong word is coming out. So a little secret is how language works in the brain. So I used to think that a person would think of what they want to say and then say it. not how the human brain works. The way the brain works is you have a vague idea of what you want to say, and in real time, you pull down words in the right order, and they come out of your mouth. Your brain organizes words into two lists. It organizes words into a semantic list, categories, small mammals, dogs, cats, hamsters, rats, whatever the case may be, and then a phonemic list by sound, sat, cat, fat, bat, things that rhyme. And as you're speaking, your brain has to go out and find the small mammal that flies and is associated with vampires, a bat, and you put it in. If your brain throws out darts and they land on two different words, you stop mid-sentence and you can't insert the word you want, and you have to go to the manual Rolodex and say, you know what I mean? It's not a banana, it's not an apple, it's not an orange. Get an orange at the store. And you have to manually do that, and it feels really odd. That word finding difficulty is completely non-specific to multiple sclerosis. Lots of things gives us word finding difficulties. And in fact, every human being at some point in existence will have a moment of word finding difficulties. What multiple sclerosis does is slow down our processing speed so the frequency with which that happens goes up. But I hate to tell you, if you have a bad night's sleep and you don't have multiple sclerosis, you're going to have word finding difficulties. I did my training back in the day before they had work hour rules, so they could make residents be on service for 36, 40 hours at a time. At hour 32, I had some word finding difficulties. And so there are a lot of things that can affect cognition. So tracking it over time can be tricky. Pain is a tricky one to track because lots of reasons to have pain. Sometimes it's directly related to multiple sclerosis. Sometimes it's indirectly. Sometimes it's totally unrelated. I had one patient who was having chronic shoulder pain and they kept being told it's your MS. They had a torn rotator cuff. And so they needed to go have the rotator cuff dealt with. And so when thinking about pain, we always have to look for what are the other issues and how to track it. Bladder function. I could spend an entire hour on bladder function or dysfunction and how it has a mind of its own sometimes, and tracking the ups and downs and the good days and the bad days based on what you drank or what you ate or how you slept is really tough. So we tend to focus on function as a way to track because it turns out symptoms are actually hard to track. You can track how it impacts your life. So you can track based on my cognitive concerns, I'm not going out to dinner with friends. Or based on my pain, I'm having interrupted sleep. But tracking the symptom itself is challenging. So if you focus on function, how far can I walk? And in Texas, that needs to be indoors because for half the year, you get really bad data. Because I step out of the front door in July and I walk 3 feet and walk right back in. So I can do 6 feet in July. Dexterity. Are you having problems with buttons or writing or things along those lines? Cognition, I have in both because there is a symptom that you describe, but you can test cognition. We have neuropsychologists. You can go spend 4 to 6 hours with one and feel like they're a CIA agent getting ready to waterboard you with all their questions, and they can quantify your cognitive function. You can repeat it every couple years. And vision becomes a great way to track. Now, you have to make sure you keep up with a current prescription, but as long as your prescription is current, we can track to see if vision is changing over time. So we encourage people to track function. And as Travis told you earlier, and I have to stress this, you can improve your function over time by dealing with a lot of different things in that comorbid category. As you strengthen your muscles, as you strengthen your core, if you make every step 5% easier, you can go longer in a day, distance-wise and duration, because you're spending less of your energy budget on every step. So there are a lot of things you can do to change function, but we want you to track it over time to see if things are worsening. So we need to merge the subjective and the objective. So you do want to track your symptoms, but you want to put a little asterisk next to it because there are a lot of things that can alter your symptoms. There are a lot of things that can alter fatigue. We really push focusing on function. You should be doing this independently of your healthcare team. You should be deciding, what am I going to do repetitively once a month, once every 8 weeks or every 12 weeks to get a sense of my function? Because if you're seeing your healthcare provider once every 6, 12 months or 18 months or however it is, you're not going to remember the averages. So you episodically need to do your testing. One of the ones we use in clinic a lot, I've recommended this for some of my patients, is something called a 6-minute walk test. You set your watch for 6 minutes and you walk. Normal speed, it's not a power walk, it's not a jog, and you see how far can you go in 6 minutes, and you write it down. And then 2 months later, you do it again, but you don't look at your old score because you're all very competitive with yourselves. And you're like, oh, I made it this number of steps, I'm going to do it again. We don't want that. We want to know how far you're going. And it turns out for people who are progressing, that distance gets shorter and shorter over time. I do recommend doing this indoors. In Texas, a mall is a great place to do it. But you probably want to either measure a distance or steps. I had one of my patients come in with her list of a year of her durations, and I opened it up and it said Auntie Anne's and H&M Fashion. I'm like, what the hell is this? And she said, those are the stores I got to in the mall. And I said, well, I'm going to need a map of the mall to figure out how far you went. So you need to record it in such a way that you can actually compare the data over time. And then future tools. We are getting better at this, but we're not there yet. MRIs are different than what we did 20 or 30 years ago. They're still not perfect, but we've been developing new techniques to try and monitor for what causes progression. So you're going to see evolutions in MRIs over time that give us more data. And then these blood-based biomarkers that are in their infancy right now, but I think over the next 5 to 10 years are going to be quite good at giving us reliable information about somebody's remission status. Are they progressing or not? So one of the last things I want to leave you with is this notion that you can alter your outcome. The pharmaceuticals that we use have been extraordinary for suppressing relapses. There is a new generation of drugs coming out that have promise to alter progression independent of relapse activity. So the drugs we use that we're going to be able to offer are going to be very different in the near term. And you should stay tuned. You're going to see this evolve even over the next year, potentially, new things coming out. But independent of anything I or any other healthcare provider could prescribe, you can alter what's happening to your body. And the number one way to do it, and I'm not just saying this because Travis is in the room, is physical activity. Maintaining physical activity is critically important. And I was thrilled to hear a lot of comments from Travis, but there's one that I want to highlight because it was at the beginning and people tend to forget. Repetition is more important than duration. I would rather you do 3 2-minute sessions in a day than one 15 to 30-minute session. The nervous system in the body needs repetition more than having a long workout. Now, if you can do a long workout, that's great. You're challenging your body more. I'm not telling you not to do that. But a lot of people feel like if I can't do 20 or 30 minutes, I'm not going to get a benefit from it. Not true. And it builds over time. And it's like watching grass grow, and it's really frustrating. So having an outsider assess you and then 3-6 months later reassess and show the progress you're making is often very beneficial for realizing that the effort you're making is paying off. So I cannot stress enough how critically important that is. So I'm lucky to have a great group of individuals at UT Southwestern, part of the Conquer MS program. I got to update my photo up there. See, that's when I had a black beard. I'm the third from the right, in between Shannon and Salahoun. Damn, I was young. But that's when I first got here. And the team at UT has been just absolutely privileged to work with just an amazing community here. And we're very grateful to any and all of you who've taken part in that community. And then as promised, when I started, my daughters were this age, and this is actually now a dated photo. They're much older now. And as I say sometimes, the younger one in particular likes to tease if I say I'm going to give a talk and it's about MS, her response is always the same. You guys haven't cured that yet? And I'm like, I get it from everybody. We're a lot better than where we started. It is a different world. And as we've had our successes, we're now able to chip away at the biology, the science, and the drugs a lot better. So what we're going to see over the next 10, 20 years is going to be night and day from what we've seen over the last 20 years. So I want to say thank you to Stuart and the group for hosting. I know Sanofi was a sponsor and our exhibitors for getting us all together today. It's awesome to share a stage with Travis. I've had a lot of respect for the work he's done here since I've been here 16, 17 years, and all of you for coming out tonight. And so happy to take questions if Stuart says it's okay. So I'm gonna have him chime in.
Thank you so very, very much. I got to let you know before, first off, everybody, I want to hear it loud. Come on, give this guy a round of applause. This was, I got to let you know, Doctor. First off, I could not have given a bio like you gave. That was great. I enjoyed it very, very much. Secondly, as you probably are aware, I have heard many, many neurologists across the country. Your presentation is a first for me of how it was presented. I was writing back and forth with my AV people and telling them that this is great. I mean, I can't wait. I can't wait for this to wind up on our YouTube channel because I'm going to blast social media with this and with Travis's conversation because both of you just did a fantastic job and the Texans should be proud to have you both there, right? We need you in Florida too.
If you're putting this on social media, send it to my daughters. That's the most fun. Look, I'm on social media.
I'll tell you what,
I don't even have Facebook, so
send it to you and you send it to your daughters,
yeah.
all right? And we're safer that way.
Yeah.
All right. First off, I've got a lot of questions that came in online. All right. So I want to know if there are people in the audience first that have any.
Looks like it. I think there's a microphone. Is that how we do this? So raise your hand and a microphone will come to you. Okay.
All right. We have anything?
Yes. Here we go.
Great.
Oh.
In here. We need a hot mic. All right. While they're fixing that, can I ask you a question?
Sure.
All right. So we have a person on from New Zealand. All right. That's how hot this subject is, you know, for people from the other side of the world to hear. And so her question is, so on the side with the, going back to your colored chart, you may want to bring that up, but so on the side with the green and the orange bars that represented relapse remitting MS, attacks, MRI findings, was the blue bar neuron loss also indicative of PPMS progression?
Yeah, so it's a great question. I'm going to restate it a slightly different way. So on the very first day, somebody comes in with their first relapse, their first event, making them aware something's wrong and they're diagnosed with multiple sclerosis. Is there already progressive biology happening? And the answer seems to be yes. Not for everybody, but for a large number of patients. And the issue is the average age of onset for relapse-remitting disease is 30 years of age. 30-year-olds have incredible neurologic reserve. You can take out a lot of neurons and not know it. So that early biology that's changing isn't clinically evident. If you ask the question, what's the average age of diagnosis or coming to awareness for primary progressive MS, it's about 45. So about 15 years later. And then if you ask an interesting question, so let's talk about secondary progressive MS. Those are people who started as relapsing remitting, and then later the relapses stop and progression begins. If the relapsing remitting disease caused secondary progressive MS, you would think that the transition happens after a certain number of years. So you need a certain number of years of the immune system punching the brain, and then people become secondary progressive. That's not the predictor. Age is. The average age of diagnosis of secondary progressive MS, 45 to 55, just like primary progressive MS. And so the thinking is that there's a biology going on all along that somewhere in our later 40s, around 50, somewhere in that age, becomes clinically evident. It was happening, it just wasn't something we could observe. And the average amount of time it takes from a person to declare to me they're worried about progression, for then me to say, yes, you're progressive, is about 2 to 3 years. You know it before we confirm it, but we sit there and we're saying, well, maybe not. And we wait for a period of time to be sure that we're not being fooled. And worldwide, the delay in diagnosis of secondary progressive is between 2 and 4 years from the time it starts to actually being labeled. So that biology is going on for quite a while, and we think it starts at the very beginning.
Okay, actually, I have two questions that go together. The first one is, I have MS and I also have Parkinson's. How do I know when my functionality wavers which disease it is? Because there's so much overlap. And the second one is, can MS impact Parkinson's, and can Parkinson's impact MS, or are they standalone?
Yeah, so I'm going to, if I can, broaden out the question a little bit, but it's still applicable, because what you're bringing up is the fact that you and many other people have more than one condition that can affect the nervous system going on at once. For some, it's Parkinson's. We've had some patients with muscular dystrophy. We've had patients with migraines where they get symptoms from migraines. And for all of these situations, how do you decide when it's the MS or not? And the basic answer is it's a challenge. It is. And this is really where careful consultation with a neurologist comes in to try and help give you guidance on which symptoms are more likely to be one condition or another. For some conditions, Parkinson's is one, there are others where there are certain motor functions that are expected to change over time and at a different rate than MS. We can usually tell someone this is the Parkinson's versus the MS. And for other conditions where there are symptoms, sometimes we'll do a trial of medication to see if we can get rid of a symptom. It probably wasn't the MS versus another condition. So it does take a lot of trial and error. But at the core of your question is, when I'm not feeling well or functioning well, how do I know if it's my MS? With all due respect to my outstanding primary care physician colleagues in the world, who I could never do the job they do, not in a million years. If somebody has MS, they tend to blame everything on MS. And so we often have to raise our hand and say, whoa, this isn't the multiple sclerosis. This is the diabetes, or this is something else, and we really need to investigate further. So having that communication between specialists and between physicians is critical to make sure we're not punting the ball into somebody else's court trying to get them to manage something. But it is challenging.
Yes. Hello. Okay. So I understand that MS can be inherited. That's what I've been told. I have two, you say not personal, but my two sons, and I was diagnosed at age 63, primary progressive. I'm just wondering does it matter which type of MS you have that can be passed down? Does that make sense?
It does, and I'm going to correct some of that information.
Okay.
So let's talk about the heritability of multiple sclerosis. So there are genetic risk factors for MS, but it is not a genetic condition. So we really don't pass it on to our kids. So if you look at the general population of individuals in the world and you ask, what's the risk of multiple sclerosis? So the other way to do this is to say, all right, let's all go to, I was going to say a Cowboys game, but let's go to a winning team. Yeah, you guys can see me after.
Don't pick the Dolphins.
Yeah, okay, Dolphin Chiefs. Oh yeah, here we go. And I can't say UT, and I'm not going to say A&M. So anyway, let's go to the Dodgers. And you walk into the stadium, and there's 50,000 people there. Statistically, how many have multiple sclerosis? So you just ask, what's the risk of multiple sclerosis? It's about 1 in 900. That's the number. It's actually a fairly prevalent condition. 1 in 900 is not that small. So if I take any person on the street, your child, and you ask me what's the risk they have multiple sclerosis, the lowest risk they can have is 1 in 900. Nobody can be lower than 1 in 900. So then if you ask what's the risk for a family member, it's somewhere between 1 and 3%. So it's significantly higher. It could be 1 in 100, let's say, instead of 1 in 900. So on one hand, you could say, well, that's 10 to 20 times higher. It's still only 1 in 100. 98 kids of parents who have MS are never going to get multiple sclerosis. So it's not a genetic condition that we pass down like other genetic conditions. So, but there are risk factors that we have. Then those risk factors can be passed down. Their overall risk is extremely low. The genetics of relapsing, remitting, and progressive MS are different in terms of the genetic risk factors. But there are things our family members can do to lessen their risk. So the things that we have found that modify risk over time is don't smoke, exercise regularly, vitamin D supplementation, particularly during teenage years, is a big deal. But vitamin D supplementation at any time is helpful, but particularly during teenage years are probably the biggest things that individuals can do to lessen their risk of developing multiple sclerosis later. So in general, we are not screening family members just randomly. We're having them follow clinically.
You talked about progress in medications coming down the pike, especially in the next year rather. What, if any, addresses repair of myelin?
So repair drugs there are multiple in different stages of trials. One finished a phase 2 trial. So for those, I think most people know, but just to make sure, there are phases before you get approved as a drug in the United States. Phase 1, small number of people for safety. We give you the drug, make sure nobody grows a second head or passes out or anything like that. Phase 2, safety and efficacy, larger numbers. And then phase 3 is the big trial to prove safety and efficacy and then submit to the FDA for approval. So once you get to the end of a phase 3, that's when things are about to come out. There's a couple drugs that have gone through phase 2 with really exciting data for patients improving functionally, and we're waiting for them to launch their phase 3. On average, phase 3 trials, depending on the design, can take anywhere from 1 to 4 years, depending on the trial design. I highly encourage people who are interested in these types of things to go to clinicaltrials.gov. It's a website. It was mandated by law that any clinical trial going on in the United States has to be listed on this website. And you can put in your zip code. You can put in anything about you want, and you can search multiple sclerosis, remyelination, and it will pull up every trial in the United States that is recruiting. You can see what the trial is, what's involved, and it has phone numbers and emails of who to call if you want to be in the trial. So if you want to keep up with that, clinicaltrials.gov is a great, useful way to make sure that everybody has an equal opportunity for taking part in trials if it's something you're interested in.
Thank you. And for anybody that needs to find that website, you can go to the MS Views and News website and look under our resources section, and it is listed there as well. All right, next. Person's asking, why is it that there are certain medications that we know are in phase 3 or phase 4 in the United States, but not yet approved here, and yet they see that they are available for use in Europe?
So it turns out there are lots of things that differentiate Europe and the United States. Fashion sense, American football versus European football and soccer, and our drug approval process. So in the United States, every country or group of countries, in the case of Europe, has an agency that is responsible for determining whether a drug has met the criteria for being safe and effective for the indication that it's being marketed. Canada has the Canadian Health Authority. The United States has the Food and Drug Administration. Europe has the EMA, the European Medication Association. The UK has their own. Japan has their own. So if you're a company with a drug, you have to submit applications everywhere in the world where you would want to market, and they all have slightly different rules and slightly different ways of interpreting data, so that you can show the exact same data to two agencies, and one agency says, looks good, and the other agency says, no, you need more data. And so it is quite possible for drugs to be available in one area, not another. But sometimes the availability isn't because an agency said no when another said yes. Sometimes it's because the company didn't apply at the same time. So some companies, for various reasons, decide to submit in one area before another, so a drug comes out sooner in one place than another. So depending on the drug you're talking about, it could be any of those situations, and you have to dig to find out which one it is.
Great, thank you. 2 more from online, and then I'll go back to in-person. Going back to pain, person asks, that he or she has a tremendous amount of lack of sleep due to just leaning too much on the left side of her body, that she's constantly got leg pain that just seems to worsen. And it's not spasticity, but it's just like from leaning on it. Does that have anything? Because her orthopedist said nothing from his end.
Yeah, so this is a great example of kind of healthcare providers playing badminton back and forth with you in the middle, trying to figure out what's going on. It's the worst situation to be in. So I'll make a general statement relative to the question, and that is, in general, pain that is directly caused by MS, meaning there's damage to a sensory nerve and you have neuropathic pain. Usually that is not position dependent. When I hear about position dependent pain, we are usually looking for compression of a nerve or a muscle or a joint in some area. So when I hear about position-dependent pain, I'm usually looking for something other than MS as an explanation. Now, that is not a 100% rule. There are exceptions to that. There are patients who have MS-generated pain that can be worsened with certain activities or positions, but as a general rule, we look for other things. Pain is a tough, nagging issue. It impacts quality of life. It impacts our sleep. It impacts our well-being. And it is probably one of the most mismanaged symptoms in the healthcare system. People either throw opiates at it, or they undertreat it, or they just want to do procedures, injection after injection after injection. And it's really important to form a partnership with a healthcare provider, and it doesn't matter which one it is, but somebody who's willing to work through systematically what's going to work and what isn't. And the problem is that takes time. And as you've all witnessed over the last for those of you who've been in receiving healthcare for 20 years, the amount of time that we have is getting smaller and smaller relative to time with healthcare providers. So you have to achieve more in each visit. So you have to come prepared and organized with your priorities. And sometimes you have to separate out your list into more than one visit. And that's just the unfortunate truth of where we are with the healthcare system. So if pain is the major issue, you need to go in ready to describe it, ready to say where it is, how it happens, when it happens. And if your healthcare provider says, we're going to do X, your next question should be, that's great. When do you want to hear from me as if X is working or not? Versus just waiting many months till the next visit. So we'll always have the action plan if the intervention didn't work on what you're going to do next.
Okay, thank you. And not the last one, but the last one I'll take for right now from online is MRIs. How often do you suggest that a person has an MRI? And do you ever suggest that they get gadolinium as well?
So I just bought an MRI machine, so I think weekly is the right answer. And no, I'm just kidding. I do not own an MRI machine. So the frequency of getting an MRI is very specific to your history and your experience. In the beginning of a person's journey with multiple sclerosis, the average is to get an MRI once a year. That's the most common. If somebody's having new symptoms, we add on an MRI often to determine if it's a new relapse or not. As somebody gets 10 or more years out, it's not unusual for us to space out the MRIs. Now, I'm going to prepare you for that may change over the next 10 years. We may bring back a more frequent MRI if the technology gets better for tracking that progressive disease. Right now, it's not good enough, so there isn't the same value in every year. So that's why we space it out for some individuals. But there may come a day where you go to your healthcare provider and they say, no, we're back to every year. And you're like, well, that's weird. It means something improved. Now let's talk about the gadolinium, the contrast. Back in the day, every time we did the MRI, we gave contrast. You had an IV, they injected it, you felt warm and funny, you didn't enjoy it that much. And the point of the contrast is to look for, quote, active inflammation. So the contrast we put into your vein, but if the immune system over the last few weeks before the MRI had crossed from the blood vessel into the brain, the contrast follows it out and highlights that area. So the contrast can tell us if the immune cells are actively crossing that blood vessel into the brain. That's why we use the contrast. And then a study came out and said the gadolinium was accumulating in cells in the body. We need to stop giving it all the time. We couldn't find a problem. The people who had the accumulation didn't have diseases that we could find. We just saw it at autopsy. We saw it in cells, and we looked at each other and said, perhaps we shouldn't use as much gadolinium. A lot of work over the last 10 years went in to find out it was certain gadoliniums and not all of them. So in our practice, we moved away from using contrast with every scan. We used it much more sparingly. But I'm going to prepare you over the next 10 years, you're going to see contrast coming back. It's like a good rock band on their second farewell tour. We're going to start using it again because it can be a useful tool. And now that we feel better about the safety of the gadolinium that's left on the market, there's going to be more usage of it. It won't be every scan, but it may be more frequent than it's been in the last 10 years.
Thank you. Two follow-ups to that just came in, one of which is concerning the gadolinium. If a person was thought to possibly have something going on 4 weeks ago and they just got scheduled for their MRI, is it too late to show a potential active lesion, or will the gadolinium still find what could have been something new happening?
So the average amount of time that gadolinium will still light something up is probably around a month. Sometimes it's longer. It can go as long as 3 months after an event, probably as short as 2 weeks. But that assumes you haven't been treated for anything. So if somebody has an active event and I give steroids, I'm going to shorten the amount of time that gadolinium is there. So if you're getting steroids and then you wait a month for the MRI, if you don't see gadolinium, it doesn't prove anything. The steroids may have solved it. So it kind of depends on whether or not it's treated. But on average, without treatment, a month is reasonable.
Okay, great. And the other follow-up to that was, person wanted to know if you suggest brain and cervical spine or just brain MRI.
It depends if I'm buying the MRI machine. No. So does everyone remember the statistic I stated a while ago on the number of orange bars to green bars? So how many brain lesions have symptoms? It's only about 1 in 10. So we've done studies over time where people agreed to come in for an MRI once a month for 3 years. And they came and they sat on the MRI for hours at a time, every month for 3 years. Those were the same people doing the spinal taps. But anyway, and what we found was over these 3 years with patients feeling fine, there were lesions that were coming and going, coming and going. It was like the 4th of July. Not everybody, but the patients were there. Lots of these events had no symptoms. So the reason we do the brain MRI on a frequent basis is, in terms of a return on investment, there's a good chance I will tell you if there's been a change before you tell me there's been a change. The spinal cord is the reverse. You tend to call me when the spinal cord has an event. So it's less than 5% of spinal cord events have no symptoms. So the utility of doing a spinal cord MRI every year is much lower than the brain MRI. Now, it's perfectly safe to do. There's no radiation with an MRI. You can do an MRI every day of your life. Nothing bad is going to happen except the bill. And so the reason we try to be judicious with the use of the spine MRI is it doesn't add as much value as the brain, and we're just generating a lot of bills for people. So we tend to use the spine MRI episodically and not every single time.
With the lesions in the brain, it's always said that there's plaque that had been of that in the lesion. So what is the plaque made of? And is there anything that somebody can take as a supplement or whatever in their diet that can lessen that plaque?
So the term that everyone's heard, spot, plaque, lesion, scar, all these words get thrown around. And what they're referring to at their core is, if we look at brain tissue, so a biopsy or an autopsy, we can see where the normal architecture of the brain has changed. But in each plaque or spot that we see on the MRI, there can be different things causing that abnormality. So for some individuals, it's loss of myelin. For some individuals, it's loss of myelin and cutting of the neurons. For some individuals, there was loss of myelin and then it regrew. But yet the scar on the MRI was maintained. It still gets highlighted as abnormal because the new myelin doesn't look as good as the old myelin. So is there anything we can do to promote repair once that inflammation has occurred? There are lots of things in study. Nothing in humans has been proven. I will tell you the top 3 supplements that we feel are safe and what we know about efficacy. So number 1 on the list is always vitamin D3, but vitamin D3 is there to prevent new issues, not repair old ones. So, and there's very good data both for safety and for efficacy for preventing new issues. Second supplement that we have good safety data on is something called alpha lipoic acid. It is in a clinical trial right now to see if it promotes repair. None of these you need a prescription for. They're at CVS or Walgreens, but it's in trials for repair. We're waiting to see the data. And then the last is omega-3 fatty acids, which play a role in myelin growth, are thought to be helpful. Now, here's the challenge with supplements. There is no regulation in the United States for the manufacturing of supplements. You have no idea what's in the bottle, and neither do I. So when they took about 10 vitamin D bottles off the shelf and they each said 1,000 international units on the bottle, on the low end there was 50 and on the high end there was 4,000. When they took, this one's my favorite actually, when they took CBD supplements off the shelf, because there was a big push in the world of epilepsy for CBD to treat seizures. And they took 15 CBD supplements and all of them said certified CBD, certified. I don't know who was certifying it, but they were all certified. 2 or 3 of them had actually more THC than legally allowed. 3 of them had arsenic in them. 2 of them had undetectable CBD. You couldn't find any CBD in it. There is no regulation in the supplement world. Every website will tell you we certify we have the best quality ever, this, that, and the other. It is the Wild West. So I know that there is a love-hate relationship sometimes in the United States with pharmaceutical industries and with the FDA. But I will say one of the nice things about what we've created in the medical world is you know what you're getting when there's a regulation around the manufacturing and the certification of it. And the supplement world isn't there yet. So I think it's safe, the 3 I mentioned, and do our best to find a reputable provider, but it is tough. So as you get the Facebook ads on such and such supplement, it's hard to know exactly what we're taking.
Hi, Dr. Greenberg. My name's Heather, and I met you actually when Dr. Froman was around, so many, many years ago. So I've lived with MS for 21 years, and so my question is now that I'm getting more involved in my MS over the decades, I'm actually questioning more of what a patient can ask for of their doctor. So I do have a doctor team now versus just an MS neurologist and an MS ophthalmologist. I've created a whole doctor team. And one of the questions I asked the team, and we're all still trying to figure out how to make this happen, is can a patient ask a doctor to test individual nerves as you go through disability progression? So an example I have is, how do you test the vagus nerve? How do you test certain other nerves? And how do you connect what lesions you have in your brain and spinal cord to certain nerves? Because right now I'm in NEDA status. I've been in NEDA status for 3 or 4 years now. But because I am aging, and aging is a topic, a very important one, with aging in mind, are there certain tests that a patient can ask for about certain types of nerves, including vagus nerve?
Yeah, so you can always ask for anything. The question is, what's the response? So testing individual nerves, particularly nerves that are internal that control function. So the vagus nerve controls a lot of heart and gastrointestinal function. There isn't a really good test for isolating the vagus nerve in a clinical way. There are surrogates. There are things we can do to look at function, but they're fairly involved. And in the setting of MS, usually don't give us reliable, reproducible data. But if I zoom out your question to the bigger one, which is, how do we test to track over time? There are limited ways from a nerve by nerve perspective, but great ways, again, at the functional level. And so part of this is democratizing our care and not waiting for your healthcare provider to collect all the data. Part of this is deciding in a rigorous, deliberate, and reproducible fashion, what are you each going to do to track your function? And then the question I would be asking your healthcare provider is, this is the list I want to use. Is that reasonable? Or is this data that's going to be useful to you for us having shared decision-making about my care and deciding are things going well or not? And recognize that the list may change over time. So you may say, I'm interested in tracking my vision and my walking and my dexterity. And then 5 years later, you may say, I need to add cognition to this list. So it's fine to add and subtract from the list over time, but we want to be deliberate, we want to be reproducible, and we want it to be something that's going to have a meaningful impact on function. If I find dysfunction of an individual nerve, if it's not affecting your function and it doesn't change over time, it doesn't add to that story. Until we get to a world where we can measure and quantify the biology, and we're not there yet, we are left with partnering up with you to decide what's the best way to monitor you, the individual. Because I'm just going to tell you, I've been privileged, and I mean that sincerely, to work now with thousands of patients, and there aren't two of you alike, which is great. I like the diversity in my clinic, but what I recommend for one may be very different than another because of your history, and because of what makes sense for you. So it really does have to be tailored to the individual. Lots of overlap, but there's definitely personal aspects to it.
Great. Thank you for that. Now, writing on what you were just talking about, what can you tell us about the NFL testing and the MSDA octave testing?
So NFL, which in Texas stands for National Football League, in your neurology clinic stands for neurofilament light chain. NFL, neurofilament light chain, is a protein that is normally in your brain cells, and a little bit of it leaks out into your blood every day. So if I take any of your blood today, there's going to be a little NFL in your blood, and that's normal. That's normal human biology. When your brain is under some sort of duress, notice I didn't say multiple sclerosis. I said some sort of duress. It could be multiple sclerosis or a stroke, or you fall and hit your head, or Parkinson's or Alzheimer's, anything that affects brain cells, that protein level can go up over time. And so we are looking at it as a way to track the disorder over time. There are groups that have found other proteins besides NFL that may inform our ability to track brain health over time. One company came out with a panel called the Octave panel that you can order, and it's a blood test, and you get back 18 different markers, and they give you a score. And the idea is to get a sense of, is MS active or not? We are still validating all of these tests. So they contribute. Many of you know, I'm sending some of these tests on individuals, and right now my batting average is about 1 to 2% of the tests I'm sending are coming back with information that changes my recommendation. Now, you may hear 1 to 2% and say, that's the crappiest thing I've ever heard. That's actually a big number in medicine. So depending on making sure it's being covered by insurance and you're not getting a bill, and making sure we have a discussion about it, we're just starting to uptick in our use of this to decide how much is it going to contribute to your care or not. The jury's still out. We are sorting this out together.
Right. Thank you. An online question I'm going to take as a person writes, you spoke about the state of research for remyelination. Where do you see the research on slowing or stopping smoldering MS?
So great question. The research on stopping smoldering MS is probably further than the remyelination. There are drugs that are thought to target this biology that have either finished their phase 3 and are under consideration, or are about to finish their phase 3 and be under consideration. So we're going to be we're all staying tuned to our computers over the next 6 months to see if there are any announcements on new data or decisions relative to drugs. So that's coming faster relative to stopping or slowing that biology that leads to progression independent of relapses. So if we do this again next year, there'll be a lot more slides, I think, to talk about that part of things.
Great. Thank you. One more I'm going to do online, going back to cognition. The person writes that they have a problem getting things done. It's like they go through the whole day and they have a list of things to do, and they look at the list at the end of the day and they find that maybe one or two from the list actually got done, whereas many other things got done. So how do you keep a person on track?
Yes, you get a family member with a cattle prod to walk behind you and just zap episodically. So I will tell you the most underutilized simple intervention to change our day in terms of productivity and how we feel is being deliberate with our time. So I'm willing to bet that everybody in the room, somewhere on them, has one of these things on them. And I'm willing to bet that on all of your devices, there's this neat thing called a calendar. We tend to only schedule things that involve other individuals, whether it's our dentist or our hairdresser or the doctor's appointment. I would encourage everyone to schedule your day. I plan from 8 to 8:30 to exercise, and it's on the calendar. I plan from 8:30 to 8:45 to do absolutely nothing. I am going to scroll through Facebook and Instagram from 8:30 to 8:45, and I'm going to enjoy those 15 minutes as much as I want. But at 8:45, I'm going to pay bills. If you are deliberate with the decisions of your time, the day doesn't get away from you and you can check things off the box. It's important to schedule the mindless activities or the relaxation or the nap or whatever it is, maybe because it keeps us accountable to ourselves on how we want to get things done. It is very easy, if we have any cognitive challenges around multitasking, it is very easy to go through the day and not achieve what we want to do because we get distracted. And so you have to be deliberate with your time and make a decision on what you're doing in that moment. And if it's not that, you're not doing it.
Well, doctor, my phone is filled with appointments every 25 minutes.
There you go.
And maybe I get 6 of them done during the course of the day.
So you also, to that point, you have to be honest with your assessment of how much time something will take. So if you schedule yourself for 20 minutes to do X and really deep down, you know, it's 45 minutes, then that's an issue. So it takes working on this and knowing you're going to have good days and bad days. Everybody has good days and bad days. You're going to have good days and bad days. And it is okay to deliberately decide to rearrange your schedule, to say, I was going to do this at 3. I choose not to. I am moving it to Thursday. There's nothing wrong with that. It takes away the emotional response at the end of the day of feeling like we failed in our day. If you deliberately decide not to do something, that is different than accidentally not achieving something. And so it really flips the narrative in terms of how we're handling our time.
What are your recommendations, the most specific ones, I guess, for older Americans, older patients with MS? And what about the meds that you recommend for people to that age group to take?
So part of my job at UT, so I'm a physician, I'm a scientist, I do research, I'm also an educator. And so we have medical students and residents who we're teaching. At some point, I'm going to die. Somebody else has got to do this. So we're teaching next generations. And a few years ago, I was on rounds in the hospital. I'm in the hospital for a couple weeks at a time, seeing patients who are admitted. And there are medical students and residents there. And we see all the patients together and try and teach them. And they present to us patients. So they will have taken a history and physical, and they stand up. And they say, okay, Mr. Smith is. And this student a few years ago got up and said, Mr. Smith is a 53-year-old elderly male. And I put my hand up, and he stopped and he looked at me, and the resident behind him starts shaking his head. And I took my glasses off and I said, I just want to tell you, in a few weeks, when you're asking yourself, when did you fail this rotation? It was now. 53 is, I'm not going to tell you exactly what I said because this is being recorded, but 53 is not elderly. Go do 3 laps on the unit, come back, and we're going to try this again. So age is relative to perspective. Embedded in your question is the truth that our bodies and our biologies change as we age, and that is true of every system, including the immune system. So there is a big discussion in the world of MS around, is there an age at which immunomodulation should no longer be done because the immune system has naturally quieted down? And the answer is we suspect that may be true. In fact, we know it's true for some individuals, but we don't know who's who. So we have had some individuals who go off their immunomodulation at 55 or 60 or 65, and then within 2 years have a new relapse event, something they hadn't had in 30 years. So we are working to try and decide who can safely come off immunomodulation or not. There are other things, though, that change in our biology as we age. The sarcomeres, which are part of the cells within muscle cells, naturally change as we age, and there is an accelerated muscle atrophy that occurs with aging. It takes more activity to bulk up our muscles as we age than when we were 20 or 30. It is critically important to maintain muscle mass relative to function. And so one of the things we push as we age is even more physical activity to try and counter some of those aging effects. So there isn't a specific medication that we would not use in somebody who is older. It's going to be very personalized to the individual, but it's an area of intense study to decide, can we test someone to decide, should we avoid certain medications?
Okay, thank you much. How about people who itch all the time and have MS?
People who, this sounds like the beginning of a great joke. 3 MS patients walk into a bar. One itches all the time. So there are a couple parts within the nervous system where if you get a scar, the symptom it can cause is itching. It's like hitting a hole-in-one on a par 5 on a golf course. You really have to get a scar in a very specific spot. So in general, I'd say 99.9% of the time, if somebody's having itching, we look for something else. There are times when it's related to a scar and we have to use either oral medications or topicals to get rid of that very nagging sensation. So it absolutely can happen. It's not the most common symptom we see.
How broad is the range of areas to be tracked?
So
And what specifically are specific ones?
So if I were to list functionally what are the most common things to be affected with progression in MS, I'm going to get the order probably wrong. Walking, dexterity, cognition, which is a broad term. Cognition covers a lot of different things: memory, multitasking, word finding, all those things. Endurance, vision, bowel, bladder, and sexual function. And then symptoms, non-specific symptoms like fatigue and pain. Those would probably be the list, the covering 99+% of individuals who have progression. It'd be something on that list. Overwhelmingly, for people who are progressing, the most common is relative to walking, but that can take the form of walking ability or endurance. So it's not just, am I walking differently? It's how far can I go? So if I use that broad definition of walking, that's probably the number one change we see if something's progressing. Do I have patients whose walking has not changed at all, but their cognition has? Yes. But just statistically, walking is probably higher.
Okay, thank you. Online, can you address the baclofen pump?
Yes. Hello, Mr. Baclofen Pump. How are you? Can I address the baclofen pump? So does everyone here know what a baclofen pump is? So baclofen is a medication to relax muscles. So for people who have spasticity after a scar from MS, there's a tablet you can take that gives an inhibition signal to the neurons that are getting the muscle to fire. So the muscle relaxes. And the problem is when you take the pill, you don't just relax that one muscle. You relax all the neurons. So some people get a little sleepy, a little tired, or it can affect cognition because it's going everywhere in your body. We discovered a long time ago that if you inject a very small dose of baclofen directly into the spinal fluid, you don't get the systemic side effects. You just relax the muscles. So we can implant a pump under a person's skin and put a tube into the spinal canal and program the pump to put in a little bit of baclofen every hour to relax the muscles. So in general, if somebody needs high doses of baclofen to relax their muscles, or they're having massive side effects, but they need the medication, that's when we consider doing a baclofen pump. For those who need it, we do a test dose before we implant the pump, and we ask them, are we functioning better or not? And so for people who get a functional benefit, we can then implant the pump and manage them. It's pretty easy to manage. They're now MRI compatible, so you can do an MRI with them. It's a pretty straightforward procedure, but it's invasive. And so we reserve it for people who really need it. And I should say in that pump, we can put things other than baclofen. So we have different medicines that we can put in to achieve different results.
So my question is, I've enjoyed listening to you. My phone, my notes, I've been very busy and I've learned a lot. Is there a way that I can continue to follow you? Do you provide information or talks like this online?
So
Only when I'm involved.
only when Stuart's involved. So I only go where
Right.
Stuart tells me to go. So myself and my colleagues at UT try to engage as much as we can in different forums. We have not done a regular UT-based online educational series. We've talked about it for years. We tend to partner up individuals like Stuart, National MS Society, local groups. There's a group here called Meat Fight that hosts events, and we'll go out and talk at their events. And so as you get involved in the community, we try to stay engaged. For some folks who are involved in support groups, if you'd like for somebody from UT to come and talk at a support group, we try to do that as much as we can. Just talk to any of the providers there, and we look at the calendar and see who can be there, because we really do value seeing everybody outside of an office visit. We really enjoy being part of this community. It's quite meaningful to all of us.
Once again, I have to thank the doctor for being here. We are like almost out of time. And I want to thank, of course, Sanofi, our sponsor of today's program. I want to say goodnight to everybody. Okay.